Hello, everyone. A very good evening to you all. Myself, Dr. Sumedha Gupta, and on behalf of Voice of Healthcare, I would like to welcome all the viewers who have joined us. So, today we are here to present the 11th episode of Detect to Protect, a series of awareness session in fight against the breast cancer, organized by Voice of Healthcare and supported by Zydus Life. In today's session, we'll explore about the vital insights on breast cancer, from recognizing the signs and symptoms to the importance of early detection, prognostic testing, policy advocacy, and the latest treatment options. So let's come together to empower ourselves with the knowledge that protects women's health. Before starting the discussion, I would like to share some stats and facts about the breast cancer prevalence in India. Breast cancer in India possesses a significant public health challenge, accounting for about 14% of the global burden. The incidence is rising at 1.5 to 2% annually, with approximately 60% of cases diagnosed at advanced stages, which severely impacts the treatment outcomes. The average age of the diagnosis is around 45 years, younger than the global average age of 61 years, and survival rates varies widely from 70 to 80% in urban areas in comparison to 40 to 50% in the rural one. Awareness of symptoms is really low, with only 20 to 30% of women informed about this disease and less than 10% participate in the regular screening. Cultural barriers and stigma further impede timely medical help, especially for the women with a family history of breast cancer who actually are at 2-3 timer higher risk. These factors highlight the urgent need for improved awareness, education, and healthcare access to address the rising burden of breast cancer in India. And in the light of these stats and facts, to begin with the discussion, first I would like you all to please join me in welcoming our expert, who is going to provide us with insightful information on understanding about the breast cancer. I would like to welcome Dr. Jyosthna, Consultant Medical Oncologist, KIMS Hospital. Good evening, Doctor. Welcome to the discussion.
Good evening, Dr. Sumedha. Thank you for the kind introduction.
You're welcome, Dr. Jyosthna. Also, I would like to welcome Dr. Ramya, Consultant Breast Oncologist and Endocrine Surgeon, KIMS Hospital. She'll be joining us in few minutes. So let's begin with the discussion point. So, Dr. Jyosthna, if we talk about the early sign and symptoms of breast cancer, so based on your observation, how does a lack of awareness regarding the breast cancer symptoms in rural area influence the stage at which the breast cancer disease is detected?
Yes, this particular question is more relevant in our country because majority of our places are in a rural background, correct? So India is a rural country, low middle income country. So majority of the patients population reside in villages, and the lack of awareness of this symptoms, lack of awareness of these symptoms, because of which our patients are coming in advanced stage. As you just mentioned, majority of them come in advanced stage, 60% and above. So basically people don't know what symptom to address, which symptom to come, and especially in our scenario where a painless lump, majority of of them feel that a painless lump is harmless. In fact, painful lumps are the ones which they need to show. That is what our notion is. So that change should come in our people, where any lump, yes, get it addressed by a doctor, and from there take it forward.
Thank you, Dr. Jyosthna, for these insights. I would like to welcome Dr. Ramya. Good evening, Doctor. Welcome to the discussion.
Thank you very much.
So, Dr. Ramya, if we talk about the early sign and symptoms, so what early indication of breast cancer do you think women frequently miss, and how can raising awareness about these indications facilitate the earlier diagnosis?
So, there are quite a few signs and symptoms that one can be aware that may be signs and symptoms of breast cancer. The most common, as Dr. Jyosthna was just elaborating, is a painless breast lump. So, apart from this, there may be a blood-stained nipple discharge, a pulling in of the nipple, a persistent redness or thickening of an area of the skin, or sometimes in very early stages there may not be any signs and symptoms. That's the reason why we may have to do a screening mammography to detect these lumps in very early stages without they actually showing any physical symptoms or signs.
Thank you, Dr. Ramya, for these insights. And following up of that, I would also like to know, so women go through a lot of hormonal changes if I talk about the menstrual changes and so many things, so breast tenderness is also one thing which occurs, and so many changes occur. So, what are the alarming signs that women should take care of and should seek a doctor in such cases?
See, breast pain is a very common symptom, as you have just said, and most commonly it is because of cyclical hormonal changes that happen in women's breast. So, as we all know, once we start having a period which is called as menarche, every cycle the progesterone goes up and down, the estrogen levels rise, and then they fall. And whenever there is surge in these hormones, we have receptors of these hormones on the breast. So even breast undergoes these cyclical changes. So the progesterone hormone effect can cause increase in accumulation of the fluid within the breast that can cause pain. So many of us experience heaviness or say just breast pain before our periods. This is called a cyclical mastalgia, which is a very common and innocuous or a harmless thing. That is not what we are worried about. Sometimes women may feel their breasts are a bit lumpy also around this time. So it's important to pay attention if this pain is subsiding, if these lumpiness is going away after the periods are over, maybe from 5th to 10th day. If they're still persisting, it is important to meet your breast oncologist and then get it checked to rule out any other, pathologies.
Thank you, Dr. Ramya, for these insights. Moving ahead with the discussion to screening part and the self-screening technique, Dr. Jyosthna, can you please provide us with the insights on screening methods when we talk about the breast cancer?
So screening methods, yeah, one is self breast screening, which every woman should know, starting from the 25 years of age. That comes monthly once. Other than that, something called clinical breast examination, which a doctor does, preferably oncologist, but any doctor. So clinical breast examination in hospital, yearly once. And then coming to the mammograms, which are the most common screening methods, the radiological screening methods we have. So mammogram is the gold standard, which starts from the age of 40 years annually once. That we have various like X-ray based 2D mammogram or three-dimensional mammograms also. So these are all various screening methods. Apart from this, we can use ultrasound also, MRI also, depending on the other factors. Like less than 40, we generally can't advise for a mammogram. So in such cases, ultrasound do help. And MRI, especially when there is a family history of breast cancer or when patients are, the people are at higher risk, like a genetic mutation is there in them. So in them, we do use MRI also as a screening method.
Thank you, Dr. Jyotsna. In following up of that, I would also like to know, at what frequency should a screening be performed and from what age, if we segregate the different age groups, so how it affect the screening part when we differentiate it with the age factor?
So, with respect to aging, majority of the guidelines say start around 40 years. Starting from there, yearly ones. Yearly ones, annual mammogram is what the general recommendation is. This is for the standard risk population. And when it comes to the high risk population, like I was mentioning, when there is a mutation present in the family or in that particular person, or any previous benign breast diseases, or any lumps which are like diseases. So, when the risk of them getting cancer is high, then we do start from 25 to 30 years also, like early 25 to 30 years also is the starting age, and in them we generally prefer MRI over X-ray mammogram.
Okay, Dr. Jyotsna, thank you for these insights. And moving ahead with the discussion, if we talk about the screening guidelines, so Dr. Ramya, can you please provide us insights on if there is any differentiation between the Western guidelines and the Indian guidelines when we talk about the screening for breast cancer?
So, in order to understand this, let us see the reason why we have to do screening first of all. So, for the diseases that are more common, it's important to actively look for the disease before it actually manifests. That is the whole point in screening. So, the average age of development of breast cancer among women across the world is around 55 years of age. In India, it's around 45 to 48. So, ideally, a screening should give us ample time to detect before this mean age. So, it's ideal to start maybe around 40. So, there are no guidelines from India except the Breast Imaging Society of India (BC) guidelines, which say the screening should start at 40. and every year it has to be done starting 40 using mammography and using an ultrasound as an adjunct. In India, there are no other guidelines. But if you look at foreign countries, especially Western countries, here the guidelines are a bit different if we compare the North American guidelines as well as the UK guidelines. The UK, the financial burden is the onus is upon the NHS trust. So they have to balance the cost effectiveness benefit ratio. That's the reason why their screening programs, and also keeping in mind their mean age, the screenings over there starts at around 55 years of age, and the screening is done every 2 to 3 years, biannually or once in 3 years over there. This model is based on many multiple decisions, not just the disease pattern. So whereas in America or North America and Australia or New Zealand countries, the onus is upon the financial burden is upon the patient, though there are guidelines. So the financial burden is borne by the patient. The screening there is recommended to start at the age of 40, and it may be done once in a year or two. So, logically speaking, for women in India, it's good to start screening from the age of 40. If you're an average risk woman, if you're an above average risk woman, you may have an intensive screening protocol, and it is done by mammography uh, from 40. And if there is a dense breast that is detected on mammography, it is likely to persist lifelong, the dense breasts. So, we may choose to do MRI in these patients if needed. So that is how the screening protocol is decided. And we do something called as opportunistic screening in India, where any lady who comes above 40 to the hospital for any reason, we recommend her to undergo a mammography as well as pap smear to detect any cancer related or precancerous changes related to breast cancer or cervical cancer. That is how it is done currently in India.
Thank you, Dr. Ramya, for these insights. Moving ahead with the discussion, I would also like to know, are there any essential steps should women take during a breast self examination, and why it is vital for them to perform this regularly?
So yeah, so breast self examination is to be done by every woman and man above 18 years of age. So, who should do it? Every man and woman above 18 years of age. So, when should one do it? A woman who has regular menstrual cycles must examine her breasts on 5th to 10th day of her periods. Any lady who is menopausal, postmenopausal, or who has irregular periods, or every man must examine their breasts on a fixed day of every month. There are two steps to this breast self examination. One is looking for changes, the second is feeling for changes. Practice makes a man perfect, right? So, only if you know how your normal breast appears, then only you will be able to detect if there's any change, right? So, you need to know what is the look and feel of your breasts on a usual regular level. So for that, start begin by exposing your body in front of a mirror. Stand in front of a mirror. Put arms by your side. See if there's any change in the size, shape of the breast. Is there any lump that is protruding out? Is there any skin that is dimpling? Is there any discharge that is coming out of the nipple? Is there any persistent redness or thickening of the skin? So again, raise your arms above your shoulder and look at the breast for these changes. So once this first step is done, then now the second step is to look is to feel the breast for changes. So feeling must be done with the flat of your fingers, not pinching like this, but you must roll the breast against your chest wall using the flat of your fingers in a systematic manner in order not to miss any particular area of the breast. Cover the entire breast on both sides, behind nipple areola, as well as your underarms. So, if you feel there's any persistent change, any new change, please immediately report to your breast surgeon or an oncologist because that may need evaluation. Don't assume your diagnosis just by Googling about what you feel. Okay, that's important.
Thank you, Dr. Ramya, for these insights. And what are the most common mistakes that women generally do during the self examination? I mean, when they come to you and ask that that is how we did that. So, what are the most common mistakes that women generally do while examine herself?
So, especially women who have irregular periods, maybe their hormone levels are irregular, progesterone persistence may cause lumpiness. So, because of that, they may feel a lump and may start worrying it may be a cancer. That is one thing. And second thing is, if a lump is too deep, then the woman may not be able to actually understand the feel of the lumps. That's another step where they can miss a already present lump. And some women have persistent pulling in of the nipple from from the time they're born. They call it inverted nipples. So once after they hear about nipple retraction, they may start worrying that they may have breast cancer. It is not so. So a woman may be born with inverted nipples, but we're talking about a recent onset nipple retraction, especially on one side. So that is another thing which, if you're not aware completely, you may mistake it for a sign of breast cancer. Other thing is, I just talked about bloodstained nipple discharge. Some women may have watery discharge coming in from both the breasts and from multiple openings of the nipples on both sides. That may not be anything dangerous. That may just be a benign disease. But I would say that it is not up to the patient to decide her diagnosis. So if you notice something persistent and different, it's better to consult the doctor than assuming, especially given the high scenario, high rates of breast cancer. It's important to visit the doctor before assuming the diagnosis. Yeah.
Thank you, Dr. Ramya, for these insights onto that. Moving ahead with the discussion to detection and the diagnosis part, I request Dr. Jyosthna to please enlighten us with that when we talk about the breast cancer detection and the diagnosis. Dr. Jyosthna, can you please unmute your mic?
Yeah. Am I audible?
Yes, yes, you are audible.
So regarding the detection techniques, so we have various modalities in it: ultrasound based, X-ray based, and then MRI. So like just now we have highlighted that the importance of mammogram in detecting cancers. So the gold standard is still the mammogram, but less than 40 years, yes, ultrasound do help. And whenever there is a dense breast, MRI will be helpful. And nowadays, there is this DBT, digital breast digital tomosynthesis. So that is nothing but 3D mammogram, where we have three-dimensional images of the breast, but with a mammography technique only. So these are the various diagnostic techniques we have, so that we can find cancers early.
Thank you, Dr. Jyotsna, for these insights. And following up of that, could you please outline the various biopsy techniques and other techniques used in diagnosis breast cancer and what patient can expect during these processes?
So, coming to the biopsy techniques, so the commonest ones which we see in our OP, like done it outside and then came, are FNACs. But these are not the standard ones, because through FNAC we can at the most say yes, this is malignancy and this is not. But we will not know exact histology, and we won't be able to do IHC on it to characterize it further. So the gold standard one is core needle biopsy. Now, how to do the core needle biopsy? When there is a breast lump which is big enough, we don't need any guidance to take core needle biopsy from those masses. But when the lumps are small in a dense breast, in a large breast, definitely we use technique of ultrasound definitely we use ultrasound help to do the ultrasound guided biopsy. So these are the ones which are commonly used in our practice: ultrasound guided core needle biopsy. But sometimes we do encounter something called incisional biopsy when they are done outside. And theoretically, we haven't seen here, but theoretically we have vacuum assisted techniques and stereotactic based techniques also, where in remote locations where we cannot localize per se, we can use these techniques. But these are very less commonly used in the practice.
Thank you, Dr. Jyotsna, for these insights. Moving ahead with the discussion to Dr. Ramya, since there are so many myths related to biopsy that if a woman get her biopsy done, that the cancer will spread to other body parts as well. So, can you please enlighten us with that and bust this myth?
So cancer cells inherently have the tendency to spread, whether we do biopsy or not. So biopsy is a method by which we're actually giving a small 5 millimeter cut in the office and under local anesthesia, a gun which goes and picks up the tissue, and there will be a sheath around that particular tissue once it is taken, and it comes out without causing any spread inside the breast. So unlike, it's a myth that the doing a biopsy is going to increase the spread. So whether or not biopsy is done, there is inherently a tendency of the cancer cells to spread from one area of the body to another. It is, and in fact, the biopsy is going to help us as Dr. Jyosthna was elaborating, to characterize the lesion, what grade it is, and what type of treatment is to be given first to have best outcomes for the patient. Not only immediate and in the long term survival, these things are very, very important.
Thank you, Dr. Ramya, for busting out this myth very positively. In following up of that, also, I would like to know what recent innovations in breast cancer diagnostic techniques have emerged and how do they improve the accuracy of the detection and can help in early detection as well.
So, for starting from how the biopsy is done, we can actually detect very, very small precancerous or cancerous lesions. We can biopsy them using vacuum-assisted biopsy, which is a machine. It can go inside the needle goes inside the breast, and we can pick up those precancerous lesions either under ultrasound guidance or stereotactic, that is under mammography guidance. So that is how small, even the small tumors can be detected. That is one thing. And once we have the tissue in hand, we can do some tests which can help us whether immunotherapy is going to be helpful, whether what is the ratio of tumor infiltrating lymphocytes, and the basic markers like the four markers of estrogen receptor, progesterone receptor, HER2, nu, Ki67, and what is the is a HER2 1 plus 2 plus 3 plus. All these things can help us in deciding the treatment for the patient. So, apart from the diagnosis on the molecular tests, if we have genetic testing available, like for example BRCA mutation, then we can actually give additional treatment to these patients to decrease the rates of recurrence and maybe to an extent improve their recurrence-free survival. So, these are the things in the molecular testing area. And coming to the systemic investigation testing, we all know that there is FDG whole body PET scan that can detect the metastases that are more than 4 to 5 millimeters size. But there is something called as a liquid biopsy, which can help us to kind of detect the cells within the blood. If the genetic material in the blood related to cancer is detected, we can know that there is the systemic spread that is happening. But as of today, we don't have any treatment decisions change depending on whether or not there are any circulating tumor cells. So yeah, of course, and day to day there are a lot of advancements happening at molecular levels to further characterize these lesions. And within the biopsy, we can subclassify what kind of tumor it is, whether it is ductal carcinoma, lobular carcinoma, what type of ductal carcinoma is it, not particular specific type, or is it a particular specific type, and then it can actually help us in prognosticating these tumors.
Thank you, Dr. Ramya, for these insights. Moving ahead with the discussion to Dr. Jyosthna, can you please provide us insights on the prognostic testing in terms of breast cancer treatment and how it influences the patient outcome?
Yeah. So prognostic models, there are many prognostic models, and few of them also have a predictive nature in it. So in that we have can assist, which is the local ones, but the original one is Oncotype DX, where it is not just a prognostic but also predictive. And then we have EndoPredict, we have Mama Print, so Prosigna. So there are so many models where we can prognosticate. What is prognosis? That this so and so patient will live for so many years without any disease recurrence, or will live so many years overall survival. So like this we have various methods, and few of them are also predictive, like I said, Oncotype DX and Mammoprint. So these are the tests which we have today, where we are routinely using also, whether to take patient for chemotherapy or only to prognosticate them and without giving any chemotherapy.
Thank you, Dr. Jyotsna, for these insights. Moving ahead with the discussion to Dr. Ramya, can you please provide us with the latest treatment methods? I mean, what treatments for breast cancer are currently being researched and how do they contrast with the traditional treatment options?
So, the most important advancement that has happened in the treatment of breast cancer is the multimodality treatment. So, we attack the tumor from multiple angles. So, there are some local treatments, there are some systemic treatments. Local treatments handle the breast as well as the under armpit lymph nodes, and systemic treatments treat the entire body for potential microscopic cancer spread or obvious cancer spread. So coming to the surgery, there are advancements. Earlier radical mastectomy was being done. Then we have moved on to modified radical mastectomy, and now we can do breast conservation surgery where we just do lumpectomy. Not only that, we can do oncoplastic breast surgery using multiple methods. We can in fact create the exact shape and size of the breast that was there even before tumor removal, despite removing a good amount of chunk of tissue. That is called as oncoplastic breast surgery. And even if we have to do a mastectomy for the clinical indication, still we can reconstruct the breast using implants or using autologous tissue. So these are the surgical advances that have happened. Coming to radiation, we have proton therapy, we have IMRT or intensely modulated radiation, and for left side we have gating with the breath holding and those kind of things, and we have the brachytherapy that can happen to some women. Not only that, the modalities of radiation, there are some protocols that can decrease. There is a de-escalation that has happened. We can have brief protocols for low risk women, especially for women who are more than 65 with luminal A or ER positive tumors who have good biology and the size is less than 2.5 centimeters. We can give accelerated partial breast irradiation where the woman has a very brief 7 day, 1 week or 5 days protocol of radiation after lumpectomy. And there is of course proton therapy that is evolving, but it's not extensively available in India as of yet. And coming to targeted therapy and systemic therapy, there are advancements in every area. I think Dr. Jyosthna would be the best person to elaborate on the advancements in systemic therapy or targeted therapy, immunotherapy in the current era.
Dr.
Yeah.
Jyosthna, you want to add on to that?
Yes, yes. So coming to the chemotherapy targeted immunohormonal treatment, there are a lot of advances, and because of which now we are seeing better and better survival, disease-free survival rates. So coming to the hormone positive ones, so where it is hormone positive breast cancer, from starting from stage 2, 3, depending on certain risk factors. Now we have in adjuvant setting. Adjuvant means after surgery, after chemotherapy. In adjuvant setting, we have something called CDK4/6 inhibitors, and in that line, we already got approval for two drugs. Abemaciclib was there since 3-4 years, and now we have ribociclib also in the pipeline. So CDK4/6 inhibitors have changed the disease-free survival rates, have improved the disease-free survival rates, because of which we are now using it adjuvant intent. That is hormone positive. Now, coming to the HER2 related tumors. So, in HER2, all these years we were using single agent anti HER2 trastuzumab commonly used for a total of duration of 1 year, combining both neoadjuvant and adjuvant. Now we started using dual anti HER2, that is along with the trastuzumab, pertuzumab also we started using. Because of which dual anti HER2, when we have given in neoadjuvant setting, starting from size more than 2 centimeter of the breast lesion, the pathological complete responses, that is the best marker that we see in HER2 positive patients. So pathological complete responses have increased from the traditional 25-30% to 60-70%. So dual anti-HER2 is the one big change that happened in HER2. Coming to the triple negative, for years together, decades together, we had only chemotherapies, and now already it's been 3 years. The approval is there, the immunotherapy for high risk triple negative early breast cancers. But all these years we have only disease free survivals and pathological complete response a little better, 10%, 13% like that. But now recently, September last month only, the final results of overall survival also has come, which has improved 5%. 5% overall survival at 5 years in triple negative high risk early triple negative breast cancers we have seen. So this is pertaining to triple negative, the immunotherapy. And in HER2 negative, means be it hormone positive or triple negative, based on the germline BRCA testing, we have PARP inhibitors now. So we have olaparib for adjuvant intent, a total of 1 year duration based on certain risk factors, again in triple negative and hormone positive. We already have that in approval, where it has improved again around 4 to 5% overall survival. So these are the various advances that has happened in the early breast non-metastatic. And coming to metastatic, again we have lot more. All this which I have told is the CDK4/6 inhibitors, the immunotherapy, and the PARP inhibitors we have. Apart from this, like just Dr. Ramya was mentioning about the HER2 positivity, I had say 1 plus 2 plus 3 plus. 3 plus is what the traditional positive we call it, but 2 plus and 1 plus, which are low HER2 positive. So low HER2 positive, in that we have a beautiful molecule trastuzumab deruxtecan. So that has come. And in that pipeline, we have many tucatinib, we have many tablets in a tablet form and injection form, which have gained approval, and we are already in use.
Thank you, Dr. Jyosthna, and thank you, Dr. Ramya, for such insights. And I think this is really enlightening to know about such advancements in breast cancer treatment. In conclusion, our objective for today's discussion was to explore and emphasize the importance of breast cancer care by integrating insights on recognizing the signs, symptoms, and the significance of early detection and the treatment options. And I'm confident that our experts have addressed this crucial topic very comprehensively and effectively. I would like to extend my gratitude to Dr. Jyosthna and Dr. Ramya for this insightful contribution and for sharing your expertise with us. Your participation has been really valuable, and we thank you for joining us today and for contributing for this important conversation. Thank you so much.
Thank you.
Thank you, Dr. Sumedha, and thank you for this opportunity from Voice of Healthcare. Actually, we didn't know this such a platform was there to reach out more people where we can record, and then later also it can be watched. So, thank you very much for the opportunity.
Thank you very much.
Thank you so
I
much.
hope it is edible.